Okay, let's get started. Happy Thursday, and thanks to everyone for joining this webinar on gene therapies for inherited retinal diseases, hosted by the Foundation Fighting Blindness. Our esteemed presenters are Dr. Christine Kay. She's from the Retinal Associates in Gainesville, Florida. And we also have Dr. Tom Mendel from the Ohio State University Wexner Medical Center. And I'm proud to say both are outstanding clinical researchers, and Dr. Mendel is a current recipient of a Career Development Award from the Foundation Fighting Blindness, and Dr. Kay is a past Career Development Award recipient. I'm Ben Shaberman, VP of Science Communications at the Foundation, and I'm honored to be the webinar moderator. And we're looking forward to hearing about a number of gene therapy related topics, including the basics of gene therapy, some current trials, gene therapy delivery approaches, and future directions for gene therapy. And in case you didn't know, if you're not that familiar with the Foundation, we are the global leader in funding research to treat and cure retinal conditions such as retinitis pigmentosa, Stargardt disease, Usher syndrome, and dry AMD. I also wanted to let you know that the Foundation's professional outreach department, led by Michelle Glaze, is educating eye care professionals throughout the U.S. about the many resources that are available for their retinal disease patients. And those include no-cost genetic testing, no-cost genetic counseling, the MyRetina Tracker patient registry. There's extensive information about diseases and emerging therapies. And we have more than 45 local chapters in communities throughout the US. So the bottom line is the Foundation can help you provide hope and a path forward for your patients that have these challenging conditions. And for more information about resources for your patients, you can scan the QR code on this slide, or you can send an email to Michelle. She's at mglaze@fightingblindness.org, or you can visit our website, fightingblindness.org, and at the very top of the website is an eye care professionals tab that you can click on. So both of our guests will present for about 20 minutes, and then we'll have time after that to answer your questions. So please feel free to enter your questions into the chat whenever you want, but we'll answer those when we conclude the presentations. So let's get started. I'd like to introduce Dr. Christine Kay. She's currently the principal investigator in 20 clinical trials. She has a large database of inherited retinal disease patients, more than 900, and more than 800 of those patients have been genotyped. Dr. Kay is also a clinical advisor for several gene therapy companies and is actively involved in the development and optimization of IRD gene therapy protocols and trial design, as well as regulatory interactions. So Dr. Kay, you can go ahead and share your screen and get us started.
Okay, let's click share. So Ben, please let me know, can you hear me?
I can hear you. We can see your slides.
And you can see my slides. Okay, excellent. Yeah. So again, my name is Christine. I'm a vitreoretinal surgeon and an IRD specialist. I'm located at Vitreoretinal Associates in Gainesville, Florida. And I have deep thanks and gratitude to the FFB for actually launching me into my IRD career through an FFB Career Development Award, which is what started me in my inherited retinal disease interest. Let me see if I can figure out how to advance the slide. Okay, these are my financial disclosures. I am an investigator in multiple gene therapy trials, both for inherited retinal disease and for age-related macular degeneration, and surgeon in many of these subretinal trials that we might discuss today. Advisor for several companies as well as listed here. And Foundation Fighting Blindness Consortium investigator for the EYS trial and the RUSH 2A trial. Inherited retinal diseases are a clinically heterogeneous group of diseases, and there are approximately 1 out of 4,000 people affected worldwide if you compile all of these into a total number. With a population about 330 million in the US, that's about 82,000 to 110,000 people in the US that have RP or some related disorder. With that said, this classifies as an orphan disease, meaning it affects less than 200,000 people in the US, and that actually gives it some FDA designations and some expedited approval pathways potentially. Retinal degenerations and sequelae affect multiple parts of the retina and the RPE and even the choroid. This is a little picture of the back of the eye and dividing into photoreceptor layers, as well as the inner retina and the bipolar cells. We'll even mention tonight how we target some of these cells with different gene therapies, and the RPE and the choroid underneath. We'll skip through this. Inherited retinal diseases, we've really launched into a new genetic understanding of IRDs because of our understanding of genetics. So there's now 300, I have to always check this and update this from RetNet, but I did update this last night. Now 353 disease genes, unless there's been one added today, have been mapped to date, and 324 genes identified. So this is a huge explosion if you look from the 1990s till now in our understanding of retinal genetic disease. And so now we have different strategies for how we combat these and how we potentially target treatments to different diseases. So gene augmentation, gene editing, and RNA-targeted therapies, we'll talk a little bit about today. Proven platform being Luxturna, Voretigene, and Parvovac is a gene therapy. That's a classic example of a replacement gene therapy where we have a recessive disease, meaning we're missing a protein. We're not making a protein, and we need to replace the gene. Vectors are limited in the capacity to replace an AAV less than 5 kilobase capacity, and that is what we standardly use today. And then some of the lentiviruses with larger kilobase capacity. This is limited to recessive disease. It is important to know the mutation. I don't know why that says agnostic to mutation. It has specific to mutation, so typo there. And some of the AEs related to gene therapy are vector-associated inflammation. We'll speak a little bit about today. And then gene editing is our potentially a novel therapy. Mutation specificity means that we could actually target either dominant disease or negative or dominant negative disease, recessive disease with gene editing. Importantly, we're not limited here by gene size. So we're not replacing a gene. We're not using necessarily replacing the ABCA4 gene in an AAV vector where the gene is limited. Instead, we're going in and we're editing the gene. So again, we can target both recessive or dominant disease here, and still be absolutely vector-associated inflammation because we still might be using AAV or other gene vectors. And then RNA-edited targeted therapy, a couple examples here. These are very different modalities, but antisense oligonucleotide therapy, and that was the ProQR Therapeutics program, now acquired by Thea. I was an investigator for the rhodopsin dominant RP program and injected a few patients with that intravitreal therapy. And then RNA editing platform. I'm also an investigator for this trial. Ascidian Therapeutics is a Stargardt disease trial investigating a subretinal injection of an AAV that edits the RNA rather than targeting the DNA. We're targeting the RNA editing, and it's mutation specific in that specific disease, and only working on half of the exons in Stargardt disease. But again, theoretically can target recessive or dominant disease. This is a huge overview of some gene therapy, and it's supposed to be a little bit daunting, but that's the idea, is to show you how many gene therapy trials are either ongoing or recently ongoing. The one FDA-approved therapy, of course, we all know, is for LCA2, RP65, Spark Therapeutics FDA approval back in 2017, which really kind of launched a huge uprise in the number of gene therapy programs and trials moving towards the clinic, and hopefully some moving towards FDA approval. But as of today, currently only one IRD, which is LCA2 RPE65 disease, that has an FDA approval, and a number of phase 1, 2, 3 trials that are ongoing. And my computer is not wanting to advance. Okay, so I'm just going to show you, just for fun, a few photos of some nice phenotypes. So this is BEST disease, BEST1 disease, hopefully moving into a clinic soon, and companies that I won't specifically mention because I can't remember what's confidential and not confidential, but hopefully BEST disease will be moving into a clinical trial at some point. This is a Stargardt disease patient. We know that there was a previous Sanofi lentivirus trial that failed to meet efficacy, but That's an example of a Stargardt patient. This is a CEP290 LCA patient, also has been addressed in clinical trials by company Editas and also ProQR. This is CNGB3A chromatopsia. I was an investigator for a subretinal trial by AGTC, which then became Beacon Therapeutics, acquired by Syncona. Achromatopsia is a cone-based disease with poor central vision, 2200, et cetera. This is an example of a patient with RP. I don't remember what gene this patient has because there are more than 80 genes that can cause RP, but this is a patient with waxy pallor of the optic nerve, bone spicules, attenuated vessels, a classic RP that you might see in your clinic. This is an USH2A patient, so they may have hearing loss as well as extensive RP changes. This is a gyrate atrophy patient and a choroideremia patient. Gyrate has not yet been in an ocular gene therapy trial, but choroideremia certainly has, even though their prevalence is extremely low, 1 out of 100,000 or so choroideremia patients. There have been multiple companies, more than 3, probably 5 different companies working on choroideremia, X-linked disease. No FDA approvals yet, but multiple phase 1/2 trials that were done to work on choroideremia. Genetic inheritance patterns is an important way to understand the diagnostic process of when these patients come to your clinic. So asking a good family history is important to help start to narrow down a genetic inheritance pattern. Dominance, pretty obvious. You might see 50% inheritance rate. Male to female would be equal. Autosomal recessive, and this is actually a misunderstanding of multiple ophthalmologists, general ophthalmologists, retina specialists, colleagues of mine. When we hear the statement that there's no family history, so it must not be genetic. That's definitely a misunderstanding of autosomal recessive disease. So in fact, the most common inheritance pattern is autosomal recessive. And most of the time, unless we have huge families, you will not see another affected family member. And that's because mom and dad were just carriers, and statistically only 1 out of 4 children would have disease, and then statistically likelihood of that affected person passing to offspring is very low unless they happen to marry and have children with somebody who has the exact same carrier disease. So very unlikely to see multiple family members with recessive disease unless they're large families, but it is absolutely genetic and passed through the genetics of families. X-linked recessive, we're going to see much more in males. We know that there's no male-to-male transmission since a male gives his son the Y. So that's how you rule out male-to-male transmission with X-linked recessive disease. Women can still have X-linked disease. In fact, we treated some in the MIR-GTX Janssen trial. I treated one female in my clinic, and she had severe manifesting carrier state X-linked RP. Genetic testing alone is not enough. And so I can't emphasize enough how important it is to close the loop and make sure the patient has the results of their test, number one. And sadly, that's I've seen that fall through the cracks sometimes on patients who get referred to me who had genetic testing years ago, never got the result. I even had one patient who I had to track down her results and found out that she had RP65 LCA, amazingly, from years ago, and had never had the results given to her from an outside specialist. And we found the results, and she's now had Luxturna on both eyes. So make sure you give your patients the results if you order genetic testing. And I think also importantly, give the patient the opportunity for genetic counseling. Even though I do a lot of genetics and do these trials, I still offer my patients informed DNA telecounseling with every single genetic test that I order. These are some of the labs you can order genetics through. I use the Foundation Fighting Blindness, my retina tracker registry, and I've used it since day one. I think I was a pilot site. We can ask Ben if he remembers. I think Jackie Duncan and I were the 2 pilot sites for that My Retina Tracker registry from years ago. And I love the FFB's My Retina Tracker registry, and it does use informed DNA genetic counseling. Right now they're using Prevention Genetics, which has actually been very rapid, good turnaround. Previously we used Blueprint Genetics, also very good genetics lab. Invitae was another option. I'm not entirely sure if that's still an option, but that was another free grant initiative or free patient initiative for genetic testing. This is an example of what a report looks like, an RPGR positive pathogenic mutation. Now I want to transition and talk about gene therapy. So we mentioned augmentation, that's replacement of the gene. That works for recessive disease, but what if you have dominant disease? Then we need to suppress or inactivate or do gene editing, CRISPR. Multifactorial disease, we also have gene therapy trials for AMD. What does that mean? We're not replacing the AMD gene. There's not an AMD gene. It's a very multifactorial disease. Instead, we're setting up the eye as a biofactory. So those of us who are retina specialists inject anti-VEGF drugs all day long in clinic. So rather than inject the protein, we're instead delivering the gene that makes the protein. So setting up the eye as a biofactory. That's addition or growth factor gene therapy. Regenexx Bio is a good example of subretinal anti-VEGF delivery. 4D Therapeutics, now Sanofi, of course, Adverum, other examples of intravitreal anti-VEGFs. And then non-genotype, I shouldn't skip this, non-genotype specific optogenetics, other types of non-gene specific therapies, some of the ocugen type of therapies that are going on, of trying to change the in a non-gene agnostic manner. That's not exactly correct to say ocugen. So optogenetics trials, specifically nanoscope would be a good example of that. So gene therapy, the genome is the genetic material. The transgene is important. So for CNGB3 achromatopsia, we're putting in CNGB3. The promoter is important. You need to have a cone-specific promoter if you're targeting cones. The vector is critical. So that's going to have serotype, tropism. That means cells that like to bind to other cells. And so the vector needs to bind to the cell of interest, needs to be specific to it, and ideally non-inflammatory, very clean. And so optimized vectors are very important. And there are a lot of companies that have spent a lot of time on developing these optimized vectors. Gene therapy, basically, we're delivering the DNA that's missing and getting that into the human cell. With AAV, we're actually setting up a epitope or episomal, an episome inside of the cell. So it doesn't integrate into the host DNA like lentivirus does. And so that's one nice thing is you can tell your patients it's not integrating into your genome or changing your genome. It's a setting up an episome still inside the nucleus. So it uses that cell manufacturing to basically end up pumping out at the end of the day the protein of the gene that we're delivering. You can deliver intravitreally. Here's an example of an intravitreal injection. The little cannula shows a subretinal injection that's delivered through a pars plana vitrectomy port. You have to get to that subretinal space through the vitrectomy. And that showed a little tiny video that I know Tom's going to show more videos in the second part. How do we get these patients? How do we characterize these patients? How do we follow them? How do we find out if they're getting worse? And more importantly, how do we find out if they're getting better from gene therapy? And that's a critical question if you're the FDA. If you're a drug company, it's important because you need to be able to show the FDA approvable metrics have been made. Of course, to the patient, it's important. And eventually to insurance companies for coverage reasons, this is very important. So not to ever minimize how we measure improvement in efficacy in these patients. And so in the small red box, sadly, on the top are the current approvable FDA outcome measures that would work for inherited retinal disease. Visual acuity, 15 letters, which is huge, 3 lines in the US. The US FDA is still requiring 3 lines. The EMA allows 2 lines, but unfortunately the US is still kind of stuck on 3 lines. Improvement or stabilization from loss compared to the control arm, and BCVA or low luminance VA. Perimetry is also really difficult. 7 decibels improvement at 5 pre-selected loci. Mobility is something that was brought into the scene with Spark Therapeutics of 2 levels of light improvement, multi-luminance mobility, light level improvement, and that's how Spark Therapeutics had their drug approved. And then anatomical measures, which are always really nice if they improve because they're so objective. You can't possibly have a placebo effect, OCT, autofluorescence. The secondary outcome measures are critical, but at the moment, not currently FDA approved, but we're certainly hopeful. And when the FFB has been very active, as well as several key opinion leaders like myself in the field of working with the FDA to help potentially move some of these other very important metrics into an approvable space, but not currently yet endorsed by any program. FDA approval outcome, again, 15 letters. There are potentials of low vision, logMAR acuity conversions, and Freiberg and BRVT ways to measure patients with off-chart, meaning they can't read those letters. Potentially, the FDA is open to the idea of lower levels of vision being approvable, but that needs to be worked out per program with sponsors and FDA. We'll just kind of go through this. So this is perimetry, an example of different types of perimetry. Humphrey visual field, we don't typically use in the IRD space. We like octopus and static and microperimetry. And then the multi-luminance mobility test as well is already approved, and many companies are using this multi-luminance mobility test. Anatomic measures, autofluorescence, and here's an example of OCT. EZ is a good example of what the FDA would endorse because it's a surrogate for photoreceptor integrity. And so if you can show a change in your EZ with over time in your treated patients versus your untreated patients, you might have an approval based off of a structural outcome. And there's an autofluorescence. There have been many trials in AMD recently. You probably have heard of Syfovre and Izervay for dry AMD. The geographic atrophy drugs were approved on autofluorescence alone. Interestingly, the EMA did not endorse them because they did not have a comparable functional improvement outcome metric. So let's just skip to that. We've already done that. And here's an example of full field stimulus testing, which I think is critical and should potentially be an FDA, should be an approvable outcome, hopefully in the future. That's a wonderful way to be able to measure rod and cone sensitivity, very specific to rod and cone specificity in patients who have low vision and cannot fixate. This is an excellent test to be able to follow metrics, and showed massive improvements in the Luxturna trial. And I'll show you one other trial today where that was a useful outcome metric. Multifocal ERG and ERG. Currently not approvable. So I'm just going to breeze through a couple of interesting trials. Varetigene Parvovec 2017 approval. So how did this drug get approved? At 1 year, the bilateral MLMT score, which is a maze, I'll show you the maze in a second, improved by about 2 light levels. Significant FST improvement. That was that test I was just telling you about, as in 2 log plus improvement in these patients. Visual acuity was stable, which is important for subretinal injection. So these patients run through a maze like a mouse, but they are measured and timed and see an accuracy and errors. And then you do it at different light levels. And so they did much better post gene therapy. And these scores maintain now for 4+ years. And so 2 log improvement, which is 100-fold improvement in FST. So these Luxturna treated patients are wildly improved after treatment, symptomatically improved. Of course, we can always talk about safety and issues, and I think Tom might talk about some of those things over time, but overall, a success to the IRD field. RP is a big category. So I'm going to talk specifically about one gene, the RPGR gene, which causes 80% of X-linked RP. X-linked RP is about maybe 15% of RP. The most common RP is, of course, recessive RP. These are 4 different programs that I'll just very briefly mention. Biogen Nightstar I was an investigator for and did not meet primary endpoint. Unfortunately, by microperimetry was its endpoint, did not quite meet statistical endpoint. Why this keeps doing that. Beacon Therapeutics is currently ongoing. The MIRA GTX trial I was an investigator for was bilateral treatment, which is completed, and we're awaiting to see when the company will submit for, have a primary endpoint readout and submit to the FDA. And then 4D Therapeutics also had a small trial. So that's an overview of all the work being done currently in RPGR, and still the jury's out whether we'll see an FDA approval, but that is hopeful. X-linked retinoschisis, this is Atacina Therapeutics program. X-linked retinoschisis is a common form of juvenile macular degeneration. Again, it's X-linked, caused by mutations in RS1. The ATS-201 is a subretinal gene therapy. Previous trials tried to do this intravitreally, and it didn't work because of inflammation and lack of efficacy. But this company at Atacina has this SPR capsid that spreads beyond the blood margin. So we're seeing 7 to 12 millimeters spread in a non-human primate with this SPR capsid that is very helpful to be able to treat larger areas of retina with the small blebs that we make subretinally. And here are 4 of 6 treated eyes, closure of foveal schisis. So this is efficacy in X-linked retinoschisis subretinal trial, phase 1/2 going on right now. You see the bottom row with the closure of the schisis, foveal schisis in cohort 1 and cohort 2, and these 4 of 6 patients. There's much more data to present that will be presented soon at, I believe, ARVO. And there's the untreated eyes. If you ask, did the untreated eyes improve? The answer is no. And there was a correlating microperimetry improvement in these patients. So that's exciting news from X-linked retinoschisis phase 1/2 trial. LCA1 trial also had some exciting final data from their phase 1/2. This is another Atacina program. So some success here with huge improvements in FST, similar to Luxturna, seen across all 3 colors tested. Oops. These patients happen to have normal retina, but really abnormal function. So gene therapy is a good target for this. And they also did the MLMT. That Atacina group used the Spark Therapeutics MLMT and had nice responses in their MLMT in the majority of subjects. So this is, I hope I can actually play this. The Lancet, notice that's a Lancet publication, so it's pretty good. Shows the final data if you'd like to read it.
No? What did you just tell me? Oh, like the big snowflakes. You could see some of the big snowflakes? Yeah. That's so cool, Aiden. Yeah, I can see them right now. You can see them right now? Yeah. There's a big snowflake in your hair. Oh, yeah. That's snow.
So I always like to show that video at the end because I think it kind of reminds us why we do what we do. So that was a patient on OHSU, Oregon patient. Andy Lauer was a surgeon, Paul Yang, and Leslie Everett, the investigator team, Leslie Everett, I believe. And that was a patient who actually was so profoundly happy after her surgery that she asked, can I share a video? And went through all the normal ways to be able to legally share a video. And so that video was posted through the OHSU site. on a patient who was treated with LCA1. So exciting times. Retigene for RP65 is approved. We have many trials that are ongoing. We have some exciting data, hopefully to be released soon on X-linked RP front. Mirror GTX should be releasing soon. X-linked retinoschisis is showing positive results in their phase 1/2, which is currently enrolling. We saw the LCA1 positive data. You can read the Lancet publication. There's so many other trials, but I obviously already went over time, so I can't go into everything. But I would argue my last 2 points are understanding that genetic testing is critical and it's the new standard of care for IRDs. And number 2, having some familiarity with clinical trials, at least that clinical trials exist, and that patients should be, we should mention the patients being referred or considered for clinical trials if they're interested. Thank you very much.
That was great, Dr. K. As you say, there's so much ground to cover. You mentioned that best disease gene therapy, not yet in a clinical trial, but a company we're invested in, we help launch. Opus is moving that forward. And there's so much more. A company called Splice Bio today announced they dosed their first patient with a protein splicing gene therapy for Stargardt disease. It's really hard to keep track of everything. So thank you. On to our next presenter, Dr. Mendel. A little background on Dr. Mendel. He's a retina surgeon and scientist at The Ohio State University and Nationwide Children's Hospital in Columbus, where he serves as an assistant professor of ophthalmology. His clinic cares for more than 300 adult and pediatric IRD patients. Dr. Mendel also directs a research team and translational laboratory to pioneer new gene therapy approaches for many inherited retinal disease patients. So the virtual floor is yours, Dr. Mendel.
Thank you, Ben. Thank you, Christine. It's always great to hear from somebody who has been doing it for many years now and can really give us such an excellent overview. There's a lot to think about, and to reiterate that point, so much that it's hard to keep track. And where I tell patients to look is the Foundation Fighting Blindness website. And I know, Ben, you do a great job writing. So I'm very grateful for the foundation, both on the local level, and we, do our walk and raise money, and then also certainly for the foundation funding my lab for the next 5 years and helping us bring some of this forward. We have a patent going international in a few weeks, actually. So we're pretty excited about some of the gene agnostic approach we have that we think we can marry with lots of different gene specific diseases. I am a consultant for Insmed and EyePoint, and I'm not speaking about them directly today. I have some BioMarin research funding for Batten disease, and then foundations on the right side there. So brief introduction, my life is a bit of a 3-ring circus. I'm a Ohio State adult retina surgeon, a pediatric retina surgeon over at Nationwide Children's, which is where some of the early gene therapy success for spinal muscle atrophy and some of the others was born, actually. And then in the center of that is my gene therapy lab where I am now, and I get to work with wonderful scientists here in the OSU Gene Therapy Institute. Throughout all of those rings, though, is the common thread of inherited retinal disease. So it's really with my laboratory and Dr. Kerr over on the right that we're able to bring things forward. I'll mention just one slide at the end about what we're doing, but tonight is not really about my particular research. Knowing that there are a number of different providers of different kinds and training in the audience tonight, I just wanted to go through a little snippet of what we think about when we start to talk to our patients about how can they start to think about inherited retinal disease treatment and clinical trials. What are the major swaths to think about? What are the major approaches? So I broke that down into a few things to help us focus for the second half of the presentation. I know it's always hard on the second half. So what are the different ways gene therapy is administered to the eye? Christine highlighted them. I'm going to show you a little bit more detail. And then how does that pro and con of each way impact how clinical trials are designed? For Luxturna therapy, the big success so far and really what opened the door to all of this, how is the therapy injected under the retina, and what are some of those specifics about how we do that? I had the good fortune of training with Dr. Basili at the Kellogg Eye Center in Michigan to do that before I came here to Ohio State. And then after injecting gene therapy, which let's not forget is a week virus, if we're using an AAV or an there are different kinds of viruses, and Christine talked about that. But is there inflammation? We already know there's some. And what have been some of the implications of that? And how do we account for that? Is the route an issue? And what do we do medically for our patients? And then what are the future directions that gene therapy is taking? There are, as you might imagine, an explosion of different directions. I'm just going to mention two, mine, and then some that we already heard about with Adsina, just as ways that are very specific at getting at some of the technical challenges. You can think about the field of gene therapy for inherited retinal disease right now as, kind of in its late adolescence. Like it had its birth earlier, about, almost 10 years ago now. And then there's been this big growth since then. And now we're really finding ourselves a little bit more. And my hope is that in the future, with more clinical trial success over the next 5 to 10 years, many of these patients that we have, as we mentioned, more than 300 in my clinics now, become not just medical retina patients that we're following and providing supportive care for, but actually become surgical or treatment patients. And this becomes a big part of what we do, the same way we think about somebody coming in with diabetes in their eye. So just a quick review of the retinal architecture. I know most of the audience probably knows most of this, and this is a zoom in on one, but let's not forget these are actual cells, not just lines on a OCT scan here. And so these are actual photoreceptors lined up almost in sort of one-to-one with the diagram. But I want you to remember that when you start to think about gene therapy as a scientist, you have to think about the actual cells and what are you doing. And there are implications for this and how you might apply gene therapy. So for example, if you're turning the eye into a biofactory to create an antibody to a VEGF molecule, say in some of the clinical trials that utilize gene therapy to do that, that might be able to be produced in many different types of cells. But if you're trying to do something very specific, like make the glue that holds the retina together in X-linked retinoschisis, that's a different kind of problem. Or, down the line, if we're working on a lot of Usher's disease problems where you're talking about a big structural protein structure within large floppy cells, that's also a very different problem. So at the scientist level, you have to think about that when you design your preclinical trials so that then you have success down the line. So major things to talk about with patients. And let me zoom out just one more bit. Most of the time, when we talk to a patient about their current molecular diagnosis, and I can't echo enough how important counseling is. I really learned this on the fly after I got here, because the importance of genetic counseling is not emphasized in many traditional ophthalmology residencies and things like that. But I have the great fortune of working with Taylor Sabato, who's a trained genetic counselor in my clinics. And she really taught me how important the counseling is. And so you're on the hook for those results, as Christine was mentioning down the line, telling your patients about them. If they update, something that was a variant of unknown significance and now it becomes a major, treatable entity, you need a system and you need people that do this. So please, please, please emphasize the counseling when you speak with your patients. But after we do that, we then pivot to sort of major kinds of clinical trials. And the bit that I'm going to talk about here is, you might say, sort of some of the more invasive or more, forthright approaches. But some patients, in fact, many patients, want to be involved, want to be part of a clinical trial, but they're not really suffering too much yet, and their central vision's okay. They might want to be part of an observational clinical trial. So I'm often cheerleading for the value of observational clinical trials first, if somebody isn't feeling particularly motivated for an interventional trial, because that really teaches us about those critical data points that then translate forward into FDA approval data points. And so being involved in observational trials is very important. The next sort of basket of clinical trials you can think about are not necessarily procedural ones, but sometimes there are oral medications and things like that that carry some risks, but not necessarily surgical risks. And sometimes patients are okay with that. But then when you turn the page to highlight some of the many successes that Christine already reviewed with you, you get to break down these interventional trials that really are procedural or surgical. And this is how you can roughly think about those. So there are different approaches: intravitreal, suprachoroidal, and subretinal. And I'm going to show you some videos of all of these. But intravitreal has perhaps the longest track record of safety, and we've been doing this with intravitreal drugs for diabetes and macular degeneration for a long, long time. It's pretty easy to wrap your head around that, but as was mentioned earlier, efficacy and safety becomes a challenge at times because it's a tall order for a gene therapy to be injected into the vitreous and then move through the vitreous, get through the inner limiting membrane of the retina into the retina, and do so without inciting an inflammatory response. We'll talk a little bit about that. Suprachoroidal is a way of getting behind the retina or under the retina, depending on your perspective, in a way that is used currently in some other approaches, and might be sort of a best of both worlds option. And then subretinal, which is kind of the gold standard for gene therapy with the success of Luxturna. But I'm going to show you that there are some drawbacks to that are being addressed in different ways. So intravitreal, the advantage, it's sort of the holy grail as we talked about, but disadvantage, inflammation, and potentially, you're putting gene product all over the eye and potentially transducing cells that are not just the retina. So this is the concept. If you haven't seen this or performed this, and you go ahead and put the needle posterior to the ciliary body in the pars plana, but anterior to the retina so you don't make a retinal hole. And this can be done very safely, very efficiently. We do this all the time. When you move forward, and I'll jump back and forth between the two here, to suprachoroidal, this is a little bit newer. The advantage, you can have possible clinical application, and you can have a longer residual time potentially than vector that goes subretinal but then is pumped out in the RPE. But there are some disadvantages to this too, and let me show you this. And again, I have no financial relationships with any of these companies, but I just wanted you to get an idea of what's happening here. And so with depression in the sclera, you have to be very careful about the depth that you depress, but this can be done safely. There are some residual questions about the possibility of a suprachoroidal hemorrhage, and sometimes patients describe some pain, but this can be done well if you are skilled at this and practice this, and they actually have training modules to do so. And then, of course, subretinal and what Luxturna actually is, and what many, therefore, of the clinical trials address. And this makes a lot of sense if you're trying to go to access the RPE or the photoreceptors. And then you make a bleb. So let me show you how that looks so you can all kind of get a sense of this. And I'll go ahead and mute this so that we can move forward. And I'll just narrate for you. I'm going to skip ahead, but this is on the American Academy of Ophthalmology website. This is typical 3-port vitrectomy. And then we move in and we lift the hyaloid. This is the gel that takes up most of the volume inside of the eye. And you have a small instrument that can move around freely back there because it can both suck the gel and it can cut away so you don't make tears. But if you turn that cutter off, you can have a strong straw and you can pull the gel off the retina. This allows you to move around freely. And then if you see any holes, as you do that, you have to go ahead and treat those with laser. Which they're doing here. This spot welds the retina down so that there is not a subsequent retinal detachment. And then this is the magic. This is the Luxturna gene therapy product. Most hospitals have a very strict protocol to make sure that the surgery is absolutely a go before you prepare the very important and very expensive vector. In terms of the details of how to do Luxturna, many providers now are clipping a 41 gauge cannula, which is very, very skinny, as you saw there, and doing so at a measured angle, depending on who you talk to, between 45 and 30 degrees. And then you can see the creation now of this blister under the retina. This is in the superior retina from the surgeon perspective. So we're intentionally detaching the retina here, which I will admit, as a retina specialist, feels heretical when you start, because you spend most of your career trying to fix this kind of thing. Notice importantly that the bleb was not pushed all the way through the center of the retina through the fovea. That's done very intentionally. When this began, many times we were intentionally detaching the fovea, and that can put some stress on the very thin fovea at that point. You can create iatrogenic macular holes, which limits your overall visual prognosis. And so this is another bleb, and the idea then, and you'll see in a minute here, is that after you have your blebs, you can then suck out all of the residual fluid. In this case, it's a balanced salt solution out from in front of the retina. And then you allow air to come into the retina or into the eye, and you'll see that air fluid exchange here. And then the patient lies on their back supine for usually about 4 hours after the case. This allows those blebs to move downhill and coalesce in the bottom of the retina. And you might wonder, well, what happens to that large amount of fluid? Incredibly, as long as the RPE pump is working, the patients are nearly flat without retinal detachment the following day. And this then allows the AAV product to get into and under the retina to access both photoreceptors and the RPE really, really well. And I will say, getting to do this a number of times in Michigan, getting to watch these little kids go from 2400 to 2040 in a month, better than the clinical trial outcomes, was miraculous. And it really charged me up to come here and try to expand this from RP65, which constitutes about 0.5% of inherited retinal disease, to the many other litany of molecular causes, as was detailed earlier by Christine. So here's that bleb. And then here's an intraoperative OCT. Very important if you're going to do this to have all of the fancy tools available to you. One important detail, when you're doing this, you have to be extremely still so that you don't make a large hole. And then secondly, you have to use intraoperative OCT to make sure that your fluid, your vector, is not cutting underneath the RPE and then causing what could be a break and then an access point for a choroidal neovascular membrane or other iatrogenic damage. So it is done well with practice, but it's certainly not the easiest form of retina surgery, and there can be some downsides, and I wanted to go over some of those now. I mentioned we're in sort of our adolescence here. So we're going to wrap up soon. I want to leave time for Q&A, but the bottom line is that there is this long-term atrophy that's happening between 20 and 30% of patients down the line that still results in good vision in the center, but naturally seeing atrophy in the area of subretinal injection has raised some questions. Is this due to the physical shearing force and creation of that subretinal bleb or intentional retinal detachment? Is it due to an overdose, for example, of the amount of vector that goes in there? And the reason they wonder that is because when you ask the investigators who do this, they're curious because sometimes the patients that have the greatest response in the first few weeks go on to develop this atrophy. So they're wondering about the total number of episomes of DNA that are in the cells, or is there some long-term immunologic response and inflammation? These are still open questions in the field. So it's important to think about gene therapy-associated uveitis. This can be well tolerated. In my mind, it's something that is not immediately concerning right after the surgery because we're pretty good at dealing with that, but it's down the line, like in the slide I just showed you, that we do need to ask some questions. So anybody who gets a retina surgery has some inflammation in the front of their eye after the surgery. It's important to distinguish between anterior inflammation and then posterior inflammation. And then short-term versus long-term, if there ever is a signal, people usually go on to address that. And so I wanted to mention, one example of an improvement in our active learning of that. So the Infinity diabetic trial from the company Adverum was it was another one of those biofactory gene therapy trials where they were essentially making one of these molecules we typically inject, not a classic inherited retinal disease. But unfortunately, one of the patients went on to develop hypotony, where the pump in the eye maybe wasn't as effective. And so the company learned from that. They went ahead and lowered the dose back down to the lower dose that they were testing in their early phase 1 and phase 2 trials. And they changed their steroid regimen. And then they've actually been able to move forward very positively in their macular degeneration trial with their OPTIC trial. And I'll mention this figure from the 2024 Lancet article, very impressive difference in the amount of injections that patients were getting monthly on the left side of this line versus the amount of injections they needed on the right side of this line after their eye was effectively turned into a biofactory for that medication. So this is another use of gene therapy, not inherited retinal disease, but a very impressive showing so far, and a good example of a smart company learning from some of these challenges with inflammation. So I'll wrap up here shortly. 2 new directions, and this was mentioned earlier with Etsina, the spreading vector, so that we don't have to pop the fovea off at all. The idea here in their image is the fovea is here. Typically, you have this vector injected into the retina, as I mentioned earlier, but they have this really unique spreading vector that can spread past the area of the bleb so that you can still get that new gene product to the fovea without popping it off. And then lastly, I'll mention just briefly what my laboratory is doing that with the wonderful funding from the Foundation Fighting Blindness. Not a lot of lab PhDs can do retina surgery. And so I thought, well, that's something I can do. So if getting through the interlimiting membrane is a big problem, why don't I just take it away? Because I do this all the time. This is me when I was a fellow at Cleveland Clinic, peeling away this stained green interlimiting membrane that you don't need, fixing a macular hole, totally different issue. And then drop in our gene therapy on top of the retina now that it's been prepared under air so that it doesn't slosh around and go to different parts of the eye. And then do so in a way, and we have a number of incorporation factors that we use as adjuvants that really help the vector get into all of the cells of the retina in a matter of minutes, so that we don't need days, weeks, or months for this to work, but rather we get the DNA cargo into the cells quickly, and then I actually remove all of the residual vector. So at the end of the surgery, there's no vector left in the eye outside of any cell to cause inflammation. So our hope is to bring this forward. We're going to be presenting this in a number of meetings coming up in the next few months, to be able to marry with many of the different gene therapy companies so that we can dramatically reduce the amount of vector we need. We can dramatically increase our safety by reducing inflammation down the line. So those are just two little, I think, unique advancements in how we do this as we move out of our adolescent phase. Thanks for your time.
That was awesome, Dr. Mendel. I love the videos and you showing the different delivery approaches and some of the new ways that gene therapies are being designed to be safer and cover more area. I'll remind our audience, you can submit questions into the chat. I'm watching the chat, so send your questions. But I do have a question for both Dr. K and Dr. Mendel. On one hand, Luxturna was a godsend because it's worked so well. And when you think about the technology, I mean, that's old school gene therapy technology, because that was technology developed, 17, 18 years ago when that trial first started. But gene therapies aren't necessarily going to all work like Luxturna. They're not going to have such dramatic results for patients. How do you communicate that to your patients, or do you communicate that to your patients? And what do you tell them about clinical trials? Because in our space, as you know better than me, people feel an urgency to do something, and maybe they're not so sensitive to risk. How do you counsel them about considering these gene therapy trials?
Christine, you've certainly done this more than I have.
I think it brings up so many good points, Ben. I think people always say RP65 was a low-hanging fruit, which I think means that it was a great disease to target to kind of prove a proof of concept disease. So it's a very rare disease. So that's always one thing. that it's, that we need to think about prevalence of disease and how we are going to design all these trials for all of these different mutations if we keep going down the mutation-specific pathway or gene-specific pathway. But RP65 was a good example of a disease with good retained structure where we just need to replace function. And then there's massive efficacy improvements, which doesn't happen a lot in other diseases. So I think in that sense, it made it challenging for the IRD space a little bit going past that to find other similar diseases. Other LCAs are good examples. LCA1 is another good example where you restore the gene and suddenly, the FST doubles, huge improvements. Patients are symptomatically significantly improved. They've turned on the light, so to speak, turned on the gene. What about, EYSRP, where patients are slowly losing peripheral field, and how do we design trials where we can follow a patient for long enough to show a difference? Because we're probably not, if we do a treatment, going to massively improve visual acuity, because most patients with RP are still 20/20 for a very long time. And to follow visual field, slow loss over time, we're just kind of banking on perimetry. So I think those outcome measures are really problematic in some of these other trials. I think the story of RP65, what I have learned from the story of Luxturna is how to design outcome metrics, how to design clinical trials with outcome metrics that make sense to follow that disease and potentially capture efficacy. And that's a huge question. I think the FFB is really good at helping us learn how to talk to the FDA, advise the FDA, collaborate with the FDA to think outside the box. So Spark Therapeutics had to design an entirely novel outcome metric, the MLMT, this maze, to really capture that efficacy. And I think other companies have learned from that. Multiple companies jumped on the MLMT bandwagon and continue to look at that. But now there are, shape discrimination tests and FST is being considered at least, or, potentially in the future, we might be able to argue with the FDA to think about FST, which is such a great outcome metric for inherited disease. So I think Luxturna really, of course, it's the first, so it's going to help. There's always going to be difficulties and kind of following that path. But I think what we've learned, what I've learned in the IRD space is we need to really carefully think about our outcome metrics and think outside the box and maybe design new outcome metrics and work with the FDA to get things across the finish line to capture efficacy if it's there.
Yeah, Ben, the only thing I would add is, I explained kind of what I was hinting at the beginning. It's one thing to just think inherited retinal disease, gene therapy, but one of the major reasons why RP65 was low-hanging fruit is it isn't a structural protein. That gene is responsible for a machine that flips a pigment from a not as useful to a ready to receive light situation. And so it allowed them to sort of shotgun a little bit, and they didn't have to be super precise. They just had to get their DNA into the right cell. And so that worked beautifully. And that's why you hear about the patients sort of having the lights turn on within just a couple of weeks. It's a much taller order for structural proteins that will then prevent degradation of the structure of the retina. And so when patients ask me, can I expect a perfect, over the moon response, I tell them it really depends on the status of the cells in your eyes right now. And we can take a look together at the OCT and we can see, where are the photoreceptors and how are they looking? And it's honestly for reasons like that I get so excited about the preliminary at CINA Day. And I really appreciate you showing that, Christine. To see a structural improvement that's so night and day is really exciting.
Agreed. Yeah, to see that schisis just go away is so dramatic. I agree. So we have a question actually from a parent who has a child with a retinal disease, and they are asking what is the best way to get the child into a trial. And I think there's a preliminary comment about a child being in a clinical trial, but maybe you can both comment on that.
Yeah, I mean, I think it depends on the disease and the age of the child, and if we have an applicable clinical trial to offer, and also if it's the right age to intervene. So it really depends, and this is such a specific question. I would say the best thing to do if you have a child with an inherited retinal disease is make sure that child has been seen by an IRD specialist. So that is one thing. that I would emphasize it would be good to see at least one time, you know, if you've had genetic testing, number one, that's important. Genetic testing important, confirm the disease, confirm the diagnosis, and see an IRD specialist to talk about potential applicable trials. There are many diseases where it might be okay to wait many years before we intervene, and safety is critical. And the young eye is more inflammatory, we think, and I've experienced in clinical trials. So we need to be very cautious and careful, and we don't want to do a therapy that's risky, especially if there might be a better clinical trial a few years later. So clinical trial selection is critical, important, and we want to think about the right time, the safe time, and maybe joining later in a trial. And that most trials are designed like this. This isn't me just thinking that. Most companies are aware of this. We typically treat adults first in the dose escalation, select a safe and effective dose, and then move in after DMC approval and FDA approval, then we move into pediatric dosing. So that is typically how things are done. But I think it really just depends on, number one, get genetic testing, and number two, see an IRD specialist and consider what might be an option.
Yeah, I would echo that for sure. I saw 7, I think, inherited retinal disease children Tuesday afternoon at Nationwide Children's. And the whole spectrum of disease, new diagnosis of retinoschisis and really tough myo7A disease, and a number of things. And so firstly, seeing somebody or a team of people who know what they're doing to even walk you through, when to test genetically. And that even has other ethical implications. And I have parents bring children in that have perfectly normal eyes, demanding that I test them for 350 genes. And there are some ethical implications of that. So you want to go to somebody who does this all the time. And then secondly, when it comes to clinical trials, just to extend a little bit on what Christine mentioned, once you are involved in an interventional clinical trial, many times that means you're probably going to be excluded from another interventional clinical trial, unless things go all the way through to FDA approval. And Christine, correct me if I'm wrong, because I know you've done this longer than I have, but usually that means you get to pick one interventional clinical trial. And so certainly with children, if their eyes are looking good and their vision is doing well, I think pausing and not jumping at something right away is definitely the safer and wiser thing to do.
Yeah, I would say I've certainly seen protocols if you've had an oral drug, but we don't consider invasive. But yes, any kind of a permanent invasive treatment, certainly a vitrectomy, subretinal injection, you're likely going to be excluded from other clinical trial protocols. And it is actually also true if you've had AAV gene therapy inside one eye, that eye may not be a good candidate safety-wise for another treatment of AAV down the road because of a potential immune response. It actually, we've certainly treated one eye and then treated the other eye, but repeat treatments is probably an immunogenic issue. And so that's also not a good safety setup. So yes, that's why important to pick and choose wisely. I also warn patients not to go sign up for things that are stem cell therapy where you pay $20,000 and get your stem cells harvested from your leg and then injected into the eye. That happened, unfortunately, in Florida, nowhere near where I live, but there have been some unethical stem cell clinics that have been doing some things and injecting into the eyes, and patients have gone blind. So you want to be careful. You should never have to pay for a clinical trial. It should be IRB approved. It should be FDA sponsored and have an open investigational new drug IND application that's been approved by the FDA. So that's why you want someone like, I love what Tom said, go see somebody who does this all day long and does this for their job. So yes, I would say make sure you're seeing the right people and getting good advice before you sign up for things.
And I know Foundation Fighting Blindness has resources to help you find those people in your region. So again, they're really an anchor point for everything from patient care to research.
Yeah, thanks for saying that, Dr. Mendel. I want to thank you both for dedicating your careers to this space. It's not an easy space. The conditions are rare. They're genetically diverse. There are very few treatments. They're very challenging. And most eye care professionals don't have a lot of knowledge. And it's important that these patients get referred up to you. So thank you both for doing what you do. You're kind of a rare commodity in yourselves. But as you said, Dr. Mendel, the foundation, we know most of the great inherited retinal disease docs in the US and beyond. and we'll be happy to get patients to the right place. Well, we're at the top of the hour. This has been awesome. I mean, I cover this stuff all day, but I learned a lot from both of you. So thank you so much for taking time out of your busy practices and days and clinics to give us this great education. And again, if any of the eye care professionals out there want additional information, mglaze@fightingblindness.org. You can send her an email, mglaze@fightingblindness.org. Thank you, Dr. K, Dr. Mendel, for a great overview of gene therapies for inherited retinal diseases.
Thank you all for setting us up. Have a great night. Bye-bye.
Thank you. Bye-bye.